So I will go ahead and call the meeting to order. We do have at least a quorum. Let's go ahead and say the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay, roll call vote, please.
One moment. Okay. Chairman Fletcher,
Present.
Glenn Bailey,
Present.
Dr. Johnson, Commissioner Cowles,
Here.
Commissioner Bertling,
Aye.
Dr. Nolan,
Here.
Peggy Cavallo.
Okay. Well, we have some members of the public. Is there anyone who wishes to make a comment?
Not this time. Is the board in receipt of import questions from Mr. Dobbs?
Yes, they are, and I have requested that at the appropriate moment in our board meeting today, I've asked Jessica to actually post Commissioner Domke's questions on the projector so that we can all enjoy the sentiment. Let me ask you, since you're here, are Commissioner Domke's sentiments shared by the full board of Bonner County Commissioners?
So, but what I can say for certain is it's shared by the majority.
Okay,
2 of the 3.
so you have 2 out of 3.
Talk to the third commissioner about his questions.
Okay,
So, yeah, and then 2 of the 3 is the board.
okay,
That's a minimum, yeah.
okay, fair enough, fair enough. Okay, thank you. And yes, we are in receipt, and those questions will be a focus of today's discussion. You're welcome. Any other comments from the public? Okay. All right, the consent agenda. Eric?
Ask if there are any questions from the board regarding any of those items. Standard items within there are the draft minutes from the last meeting, division reports for major programs. It is the time of year for grants and contracts to come through, so there are a number of them that are identified here below. These are contracts or grants that we have received in the past, so I answer any questions regarding them.
So if there's anyone who wants to extract an element of the consent agenda, now is your moment to have further discussion. Going twice. Yes, ma'am.
I would just like to comment.
Sure, go ahead.
I don't want to distract anything. I just appreciate the work that the staff is doing and the work that they put into the reports, because it just seems like we're out there, the staff is out there really doing a lot of work and a lot of good work. And I appreciate the time and effort that they put into the work and it should get done in the reports, because it's all pretty fun.
Okay, thank you for those comments. Going a third time, any extractions? Hearing none, do I hear a motion to accept the consent agenda?
Motion to accept the consent agenda.
Do we hear a second?
I'll second.
All right. Any dissents? So speak your mind. Otherwise, the consent agenda is affirmed unanimously. All right. Please, for purposes of records, note that Dr. Johnson has arrived. Election of officers. So last time we had one office that ended up in a tie. And so that position is going to come up once again for consideration. That is the position of the trustee. Let me just as a once upon a time, the trustee actually had a meaningful job because they were part of the mechanism that divvied up the pie. And, whenever you're divvying up the pie, that attracts attention. But now the state legislature has more or less developed a methodology by which the pie is already more or less distributed. And as a matter of fact, much of the responsibility for the pie's distribution is in the hands of the commissioners. So I think the intention of the legislature was to actually put more responsibility at the local level. Speaking for myself, frankly, I think that was a smart move. That being said, there is still theoretically a position of the trustee, and I suppose we should try to, fill that slot. So, I will entertain nominations.
I would like to nominate Joel, if I may, as I did prior to. I think that experience would be educational, as he's new on the board, and would be helpful.
Okay, do I hear any other nominations?
I'll nominate Glenn Bailey.
Okay, do I hear any other nominations?
I nominate Joel Nolan, Dr. Joel Nolan.
Oh, Commissioner Cowles,
Yes,
welcome.
thank you.
We appreciate your attendance. Thank you.
Yes.
All right. All right. Any other nominations? Okay. I'm not sure a nomination requires a second process, but thank you anyway. I appreciate it. Any other nominations for a third human being? Okay, hearing none, let's have a roll call vote, please.
Yeah, I'll name off the nominee and then do roll call.
Now, wait, before we go there, do we want to do this closed vote or open vote? I frankly don't really have a strong opinion one way or the other, but I do appreciate that there are sensitivities or, feelings. Is there anyone who expresses an opinion one way or the other? I'm willing to go anyway.
I'm fine with it.
Okay, well then, go ahead, roll call vote.
Okay. For Glenn Bailey, let's get that. Chairman Fletcher,
No?
Glenn Bailey,
Yes.
Duke Johnson,
No.
Commissioner Cowles,
No.
Commissioner Bertling,
Yes.
Dr. Nolan,
No.
Peggy Kavala. For the nomination of Dr. Nolan, we'll go Chairman Fletcher,
Yes?
Glenn Bailey, Dr. Johnson,
Yes.
Commissioner Cowles,
Yes.
Commissioner Bertling,
No.
Dr. Nolan,
Yes.
Peggy Kavala.
And?
Dr. Nolan was
Okay.
nominated or was in favor.
All right, thank you, everyone. Let's go to the next agenda item, number 7. Peggy, I believe you were the one who introduced this topic. Please, would you?
Well, there was discussion, I believe, in April, that we talked about, once we had all our.
Can I interrupt for just a second? Sorry, Mr. Chairman. Some of you I can't hear, so I don't know if the mics.
I turned my mic on now.
Okay, because some of you I can't hear, and I didn't even realize that there was already a nomination. And I couldn't hear Peggy. Sorry.
It's okay.
Thank you.
So the reason I brought up the Board of Health training is that we had discussion, I believe it was April, our April meeting, that once all the new members were part of the board, that at that time, he would look at doing some board training. And I think it's important, there's a couple things in regards to the last meeting that in my experience, I've, served on public boards for quite a long time. I just was not familiar with the process. So there's certain, processes that I want to make sure that we're all very clear of what is our process and how we conduct business in a parliamentary manner. So I think, board training, would be a perfect opportunity for us to do that, as well as I'm just familiar with organizations where the bylaws were looked at every year. And, if they need a review or if they needed updating, there was an annual review, and I'm used to bylaws that, quite frankly, cover a lot more information.
Okay, any other comments? Yes, sir.
I mean, I generally think that's a great idea to learn the basic, make sure everyone's kind of up on the same level of knowing the order and the rules and all of that. I think it's a great idea. And I think I would benefit from it. I think I looked at that and thinking that, because I'm on another board too, and so we also are constantly trying to review and learn all of that stuff. But there's like the Idaho Association of Counties that I think provides trainings for that too, so that they're one option we could consider. We kind of look at what kind of curriculum's available, and then see what curriculum we feel looks great, and then get trained. That would be an option.
Any other comments?
Yes, Mr. Chairman, I agree that it's good policy to review the bylaws. It makes new members of the board familiar with it. We discuss the current bylaws and do they need to be modified, are they adequate, those kinds of things. It's good policy, I think.
Any other comments? I'll take this opportunity to comment then. I wholeheartedly agree with you. I couldn't agree more. So what I would propose is that we advance your discussion as an action item at the next board meeting. And in the interim, I would propose as a homework assignment to the board members to give thought as to who we should invite to conduct the seminar, the training. There are, in fact, different opportunities. They have a different cost structure. They have a different curriculum. I would certainly defer to commissioners, because I think you guys almost per force, the IAC sort of puts you through the training, and I've never had it. So if you have experience with people who give this training, I think that's.
I could reach out to Seth Grigg on that.
Yeah, that's
And-
kind of what I'm thinking.
Yeah,
The
and talk to
word
them.
on the street that I've heard, and this is what I think Dr. Nolan was saying, IAC puts on a really good program. And it seems to be recognized across the state, and at least we would all be on the same page. In other words, what you've been hearing would be the same thing we're hearing, and so on. So, but if there's someone else, I don't want to exclude any other provider. But so that's the homework assignment. Come to the next meeting with with having given thought to who should give the training, and then it will be an action item. Peggy, does that meet your satisfaction?
Yes, I think that's
Oh, and by the way, you mentioned actually two things, Peggy. One of them was this board training, which I'm 100% in favor of. And the other has to do with bylaws. Frankly, I can think of a couple of items that I would like to discuss as it relates to bylaws. So, in your spirit, there's another homework assignment for board members. If there are topics that you would like to see addressed in the bylaws, then I will make sure that it is an item to be discussed. Now, it would not be an action item because you're going to need notification for bylaws changes. We can't do that impromptu. But we can certainly make it a discussion and, if you will, tee it up. Is that favor to everyone? Peggy, are you happy with that? Okay, so does anyone else want to talk about item 7? Okay, let's move to item 8. And Jessica, if you would be so kind as to project Commissioner Domke's letter. No, that's my lecture. You're going to have to suffer me at the end of today's meeting. I've got to.
How long a lecture do you have? I already suffered earlier today.
You don't want more indigestion? Yeah. I know, we're going to get there. Okay, good. There we go. Yeah, that's fine. Now, Medical Director Selection Committee, Doctors Johnson, Nolan, would one of you be so kind as to address the issue? Okay, go for it, Dr. Nolan.
Just so everyone knows what we've been kind of doing the last month, we had HR publish a nationwide advertisement for it on Indeed. It was Indeed, yes, yeah. And so we had a total of 3 submissions. We also, the chairman requested any commissioners that had any good candidates they wanted to put forward to submit candidates as well. I think Eric also just reminded everybody via email too. So that was something that we were hoping that would be. So we had in the first, I think it was 4 to 5 days. I'm not sure exactly when they arrived in the Indeed. We had a total of 3 applicants. 2 of them were out of state. We held interviews with each one, about probably 45 minutes to an hour interview with each one after reviewing their resumes. And so we found that though all of them had various qualifications, the 2 out-of-state ones were needing a full-time position, and being that it's, I'm not sure what we do that, but like 1 FTE or something, it wasn't really a good fit for what they were needing on that level. And so there was good contacts. And so then we had a local doctor physician that applied, is fine with the hour requirement limitation. And we also, it was Dr. So that basically Dr. Pindock was the one who we interviewed with, and basically, let me tell you some notes here. So he's got quite an amazing resume. I don't know, were those resumes? Those were not circulated right now. So yeah, he's got a very impressive resume. He's got multiple decades of experience at helping run successful clinics, including helping with like management and analysis of everything from like the billing and the insurance and the reimbursables and all of that to protocols and procedures and everything on that level. So we felt that he was a great candidate, and so that's going to be our official recommendation from the subcommittee, the search committee, for that. So just let you know that Dr. Greg Canuck is a physician. He lives.
And I believe he has some extra resumes.
Yes.
Peggy, would you like to see a resume?
And
Oh, absolutely.
and we have resumes that we're going to have a little bit of time to ask questions. I believe, is that correct?
Yes,
yes.
right.
And so, but we all were quite impressed. He also has a great disposition. I think he's really excited and encouraged about working with the director and helping all of the aspects of the services, since there's also some changes and stuff that to really make it a great program for all of us. We're looking forward to serve the 5 counties and Londons, make sure we're hitting our core requirements and goals. So I'm gonna do a motion how does that go? Do I need a motion, or just anybody want to talk about it
A
first?
standing subcommittee is actually a motion.
Okay, so our official recommendation is Dr. Greg Pinnock. And I guess I'll turn it back over to you if you're wanting to.
Well, I would open it up for discussion.
Yeah.
So we have a recommendation from the subcommittee. Also, Dr. Pinnock happens to be here. I had invited him to come, and I would actually ask him, I don't know if you want to, why don't we hear from him? And then I would invite board members to address their questions to him and let the discussion evolve as will. So, Dr. Pinnock, why don't you find a spot? Do you have more copies of your CB?
I have one more.
Okay. When would you like one?
When you
Yeah.
get done, when you get done with that, that's it.
Oh, you don't, okay, I didn't get through it.
Well, you can look at it. Whenever you get done,
Oh.
that's fine.
And if needed, I do have the medical director bylaw thing up if anyone has any questions for that. Already have the text.
I only have,
The medical director and the bylaws.
have two, but I'm happy to email copies of my CV to anybody else that would like them. So I appreciate the opportunity to be here today. Let me tell you a little bit about me. First and foremost, I'm an Idaho. So I grew up in Southeast Idaho, graduated from high school there, went to undergraduate school, University of Idaho, graduated with a chemistry degree from University of Idaho, went to medical school, Washington University in St. Louis. And then the rest of my training was in Arizona. So I spent 30 years in Arizona. I finished an internal medicine residency, cardiology fellowship. And then we started coming up to northern Idaho, looking back to my roots of coming back here. Really enjoyed the area around Sandpoint, eventually bought some property in Sagal, built a shop and then a home eventually. And so we moved up here full time in 2018. So we've been here full time since then. I practiced in Sandpoint for a couple of years at Kootenai Health Clinic and enjoyed that experience. Then I got called back to Pocatello, where they wanted a chief of cardiology position to be filled to help them with some of the problems that they had down there. So I took that opportunity to go down there. It was kind of right in the middle of COVID. It was a tough time in the medical community for any good practice. And I think in the end of 2021, beginning of 2022, I was a little bit burned out, and I think we decided to retire. So we came up to Sagal and retired. I didn't stop learning, though. I spent a lot of time reading, learning still. I think kind of reinvented myself a little bit. Learned about things that I hadn't learned about in medical school, nutrition being a big one. Things like that I think kind of broadened my experience, things that I probably wish that I'd have known when I practiced. So gained a little bit of breadth. And now I'm kind of reinvigorated. I saw this position come up. I thought it'd be a good opportunity to perhaps lend my expertise and help the Panhandle Health District. So how can I be of help? First of all, I'm a clinician. I'm a clinical person. I've spent my whole career seeing patients. So I think this position demands being a clinician. So I've seen thousands of patients, taking care of lots of people. I think the second thing that is important is what Joel mentioned, and that's the clinic experience. So I've had experience in academic medicine, government medicine, through the VA, private practice, both working for somebody else and owning my own practice. So yeah, I'm familiar with everything from the front desk to the clinical operations to the back office, collecting insurance money, the whole bit. So I've done it all for the most part, in private practice at least. And I've worked for, we ended up selling our practice, and I've worked for corporate medicine, which is tough. Not something I recommend, actually. So here I am, and I'd be happy to answer any questions that y'all might have.
One thing that was of note was some of your undergraduate research kind of, I think, it was kind of interesting for public health too. I don't know if you comment on that, just because that was
Yeah. So at the University of Idaho, although my degree was in chemistry, I fell into a lab of a wonderful woman, Lois Miller, who was a molecular virologist. And she was interested in plant viruses for use as fertilizers in the area. Is there some water that I can?
Yes, one.
Yeah. So Lois trained me how to be a molecular biologist and to manipulate viruses. And I learned a lot about the process of doing that. And in fact, one of the viruses we worked on was instrumental in the Novavax vaccine, the baculovirus, producing vaccine for that company. It was kind of the basis of that project. So learned a lot. Probably got me into medical school, no doubt. So, and I still kept kind of a research twist to my career up until I started seeing patients, and then I realized I'd rather see patients. So I came back to Arizona. I still was involved with research, published some papers, but eventually my heart was with patients. Sure. Anybody else?
Glenn, you have a question?
Dr. Pinnock, how frequently do you have to be certified in the state of Idaho? You aren't currently practicing.
Yeah, no, it's a great question. So the state of Idaho requires 20 CME per year, approximately 40 every 2 years. So I've maintained my license in the state of Idaho and in the state of Arizona. So I've fulfilled that CME requirement. But above and beyond that, I've retained board certification both in cardiology and internal medicine and echocardiography. So 3 board certifications. I didn't have to do that, but I like to learn. So, and sometimes during retirement, you look for things to do. So I like studying.
Mr. Chairman, one question. Good.
Oh, yeah, sure, of course.
So how familiar are you with the operations of the health districts in the state of Idaho?
Yeah, great question. I've attended a few of the meetings, so mainly through learning through you guys. I've become a little bit familiar reading about what I can online. But I think for me, it would be a tremendous learning curve in the first weeks, let's say, of the job. So what I would envision is spending time with, first of all, Eric, and getting the overview of what the clinical services are from his perspective, talking with the board members, hopefully, and seeing what their perspective is. And then perhaps talking to staff, seeing what the clinical operations are, and observing, listening to people, trying to figure out, what you do here. I think it's important work. I think it's great work. And my goal would be to, leave what's good intact, and let's make changes if we can to make things better. But I have no preset agenda of what that means.
I have a question.
Sure, go ahead.
So you've watched a couple of videos.
Yes.
And would been interesting. John, can you talk a little bit of, what is your philosophy of things?
Well, it's a great question, and I've thought about this. And what I would say is it's a lot like practicing medicine. So if somebody comes into the office, I treat that individual and do what's in the best interest of that person sitting across from me. So I think the goal of public health is to expand that across the population. Do what's best for, thousands of individuals. I hope that answered your question. That's a general philosophy. That's a short answer to a complicated question.
Well, it's just, we're sort of in a flux right now with clinical services.
Yeah.
Because of that, we're going to discuss services at this meeting. We have a workshop in May.
Well, I attended the workshop in May for part of it. I had to leave prematurely, unfortunately. I thought it was a great meeting. One of the things that I got out of it is the importance of regaining trust, or at least improving trust for Panhandle Health. And I think that would be a huge goal of doing this. And, I don't know what that means exactly, but I think, again, my process would involve listening, learning, talking to people who understand Panhandle Health, perhaps talking to commissioners who would want to talk to me, health leaders around the area, get their feeling about what are the important needs of the people of Northern Idaho, and then try to marry or merge the needs of the people with the clinical services that Panhandle Health offers, and find that niche. I mean, Panhandle Health can't do it all. They don't want to do it all. We don't want to do it all. So find that niche that benefits the public in the best way possible. And I don't know what that is right now, but that's, one of the questions that I have along with others.
Do you have any thoughts? Because right now, we've had our first regional case, which is pretty historic for North Idaho. And as I read in the reports, we had over 400 cases of pertussis this last year. And both of those being vaccine your thoughts about vaccine.
Sure. So I think it's a good idea to step back, first of all, and say, in the big picture of Northern Idaho, what are the preventable health issues that we have? And 2 measles cases makes the news, no doubt about it. I don't think either of those patients were hospitalized, as far as I know, right? There was one from Kootenai County, there was one from Bonner County. In the same time period, 2025, 300 people died of heart disease. Now, I'm biased, and I'm not saying we shouldn't monitor infectious diseases. Absolutely should. And I think we should vaccinate when appropriate. But I think there's other public health problems as well that probably need some attention, and we should look at those as well. If you do a quick AI search, and I know we're going to talk about AI later in the meeting, but if you search preventable diseases in Northern Idaho, you get heart disease, cancer, diabetes, obesity, accidents, behavioral health problems. And infectious diseases don't make the top 5, maybe even 10. So they're important, no doubt. Important to monitor, important to watch, important to treat. important to vaccinate. But we need to put that into perspective of everybody in the area. And if there's other things that we could do to get more bang for the buck in public health, then we should be looking at those. Sure.
Any other questions? Yes.
I was just thinking that there's a nice little synopsis on the first few points on the general, what is the position? Because this is a new position for us, really. Right, and I think there's only one or two other districts that maybe have this position in Idaho. And so the position of the bylaws, like if you look at my read, just the first few lines here describing.
Sure, of course.
Yeah, so basically, the responsibilities include serve as medical consultant for clinical providers and epidemiologists. So that would be wanting to have, extensive consulting experience. And then provide oversight of public service health advisory program, which is one of the things we do. And then assist with the establishment and maintenance of medical policies, procedures, and standing orders. And also review risk-benefit analysis and stuff. So basically, the main criteria for this job would be someone who's had a lot of experience doing both consulting with other providers and helping establish policies and procedures and stuff, having run a reasonably sized clinic for decades. And so being that in his resume, he's definitely done that, we felt that that he kind of fits those specific requirements there on that part. And he doesn't replace the board nor act independently on that level. So I think this is my understanding. So just bring that up because that's
Commissioner Bertley?
No.
Any questions?
Nope. He answered them all.
Lynn, have you got another question?
So as far as the job description, you meet most of those requirements, or do you see it as an evolving situation?
Well, I feel I meet those requirements, and my assumption is that I would work with the board and, at your pleasure, and make sure that I'm doing what the board wants to do. I mean, that's part of the position as well. So, but I'd like to bring the information as I see it to you guys so that you can make an informed decision and move things in directions, or not move things, as the case may be, in directions that you see fit.
Just a point of clarification here to follow up on your question, and it's a very good question you asked. You will recall that we modified the bylaws last year. And you will recall that the very last element in the job description of the medical director was that there is a mechanism by which the board has ultimate say-so over the actions of the medical director. So in other words, should we hire Dr. Pennock, it is not possible that he can go rogue on us. I mean, if all of you faces in this room are his check and balance. Per our bylaws, he is responsible to us, and as it should be, by the way. And he acknowledges that. In fact, he said it multiple times.
I'm not a rogue kind of guy. No, I think it's, you guys were elected the position, and I'm going to give you the information, hopefully, that you need to make good decisions.
Any other board members want to ask questions? Commissioner Cowles, do you have a question? You're kind of, I don't want to leave you out.
Oh, I know. I'm sorry. I got a lot of things going on. No, I don't. I don't have any right now.
Oh, Peggy, you have another question?
I have a question for the committee.
For the committee. Oh, yeah, sure,
So I was unsure, like, in your process, did you have professional references? Is that part of the process? And did you look at claims history? And did you guys discuss the whole you know, is the malpractice just like through the state?
Well,
of
in his
Idaho?
case, I can answer, he's never been sued. So therefore, there are no claims.
That's
And as far as references go, look at his CV. I mean, it's stellar.
As far as the other two candidates, we didn't take at that point because they both needed full-time work. And when the conversation, though, we did a full interview and got their full history. At the end there, said, well, I really need full-time work. And so we didn't go beyond that because the position was not something that they wanted to actually, they couldn't do that. So, yeah, if that makes
I
sense.
just have been familiar, you know, when we have hired positions
Yeah.
in the hospital setting, we usually have a
For sure.
process where we look at the data bank
Yeah.
and
Well,
we just, you know, and you probably
Yeah.
had discussion about liability coverage. Guessing at some point, the committee discussed that.
Oh yeah, for sure. Yeah, I brought that up too, and something of definite interest to Dr. Pinnock also. But the idea is that the liability coverage is something that we're going to have probably the standing committee is going to be working on with the directors, trying to figure out what's the most appropriate for that. But that definitely will have to be, we were considering getting more into that after an approval was made by the board. And so, but it was definitely discussed as something that would be needed. And we just have to figure out with what's going to be standard working with Eric, with other providers, as well as what his exposure would be if he gets approved. So that we can make sure that he's, covered. So.
As far as getting letters of reference, under normal that's always a good idea. But Afa Torai, when you look at his CV, if he is invited to be chief of cardiology of a program in Pocatello, again, Afa Torai, this man is qualified. I don't need to go and reproduce, reinvent the wheel.
I'm just explaining the process I was used to because
Good question.
along with the CV, there were also, written letters of reference. So I was just trying to clarify how the candidates were.
Right. Any other questions?
Mr. Chairman, we're on item 8.
Yes.
Okay. Could I get clarification on what the action item would be
To approve him.
to approve? Yeah.
Mhm.
Okay.
Glenn, if I may, my understanding is that the search committee, being a committee, presents him as our recommendation. That is the nomination. And correct me if I'm stepping here, but so that is the nomination. So then at some point, I guess there would be a call for a vote that we then would vote, probably an open vote to determine if we approve them by a simple majority. I think that's the next step.
Mhm.
Yeah. Usually, we would be going into closed meeting to discuss the things without the individual being present. And then we would come back out.
Well, we can do that if you prefer. We can ask him, we can ask everyone to leave the room and then we can have a discussion if you'd like. Sure.
You won't hurt my feelings if you vote no, but I'm happy to leave.
No, I hear you. No, that's a perfect, no, I got it. That's a perfectly legitimate point. I, no objection. Yes,
Is
Peggy?
there an issue with open meeting laws because we did not have executive session on the agenda?
Yeah, you can have it on the agenda.
You don't
To-
need to.
You know, why is that? We've always had it where if you're going to go into exec session, you have
But
to have it on
one
the
can, one
agenda.
can request going into executive session during a meeting.
It has to be agendized. It
I
should-
don't think so. I don't think that's true.
Maybe that's the most common.
I just know, you're probably tired of me talking about my past board experience, but we actually used to have executive session on there, even if we didn't need to go into executive session.
Fair enough, but one can go into executive session. In fact, we can have that vote right now. I would make a motion. Who wants to go into executive session? Let's have a roll call vote.
It should be underneath on the medical, on the agenda, underneath the medical director selection committee, should be executive session 74-206 A or 8B.
Okay, and I hear you,
Yes.
but an executive session can be called
Ad hoc.
If ad hoc.
Request of two. or
at the
more.
request of two board members. That's correct.
We had this question in the last.
Yes, Commissioner Corn. I'm sorry? No, but it's in Robert's Rules of Order. Yeah. Yes. It takes just two members to call for an executive session. Are there two members, board members who want to go into?
Question on that real quick, if I might, for Commissioner Corn. Are you saying that your understanding is that it's not in our bylaws specifically that it may not be allowed that to be?
So when it comes to government agencies, we have to notice an executive session in 24 hours and time of week. But we do not follow Robert's Rules of Order. And so if you guys have in your bylaws that you are using Robert's Rules of Order, and Robert's Rules of Order state that.
Okay.
There's accountability.
Oh, okay, I didn't know. Is there an interest in going into executive session?
Okay, so I pulled up the open meeting law checklist. Now, this just says executive session only. Meeting and agenda notice posted at least 24 hours prior to the session. Executive session during regular session. So I guess you need a motion. You have to list the reason why, but maybe you have to have a two-thirds vote.
Mr. Chairman, if I may add, a few meetings ago, there was a question on if we followed bylaws or if we followed Robert's Rules of Order, and our bylaws do not specifically identify if we do or do not follow Robert's Rules of Order. We did try to look back through the history of the Board of Health to see if there was some clarification on that, and we were unable to find that.
So what you're saying is silent.
Correct.
Well, this might be a reason for bylaws examination, Peggy.
I'm looking at.
Maybe we just found a lacuna.
Yeah.
All right, look, I'll tell you what.
Okay.
Fine, if there seems to be some dyspepsia on this, then I'm going to propose the following. I will call a phone meeting of the board to be held, say, Monday. It will be, by definition, an executive session. It will be 24 hours advance. We will have this conversation. We will come out of that executive session, and then we'll take a vote.
Yeah,
So-
so possible alternative to that.
Yes.
Says, under the open meeting law, it says for 206, executive session can be called ad hoc during a properly noticed public meeting, which this is. This is initiated through a motion that identifies the specific statutory subsection authorizing the session, such as a personal matter, litigiousness, discussing an employment issue, followed by roll call vote, recording the minutes, motion required two-thirds. That's what Amy was saying. So it can be, but it has to be a motion with a roll call vote. And then
Right, well, that was my
understanding.
understanding, that you actually could, you
I'm
could
fine
call
with
it.
Yeah, we've never done that.
Yeah.
Well, apparently, the commissioners don't,
Yeah.
according to Commissioner Corn. Look, what you've just said was my understanding also. I've been advised that you could, in fact, with cause,
Yeah.
go into executive session.
So we just have to.
Parenthetically, if you're in executive session, the reverse is also true. You can pull yourself out of executive session. You can go either way. You can go in and you can come out. why don't we just have a roll call vote? Who wants to go into executive session? And
We have to first identify the exact subsection of the code. And once we initiate that by saying that out loud, then we can have that.
do you have the subsection
I'm
code?
working on
Well, look, like I said, if it causes dyspepsia,
But, you know, I think, Mr. Chairman, if we could allow him to determine the correct subsection for that number, it would save us all a lot of time and not be an additional meeting. You know, if we could handle this right away, that would be great.
okay,
it. I concur. I may be busy on the meeting.
I'm just trying to be accommodating.
The only question I have is that since we are going to discuss clinical services, I don't know if we need to hear that discussion before. So that would be the only thing I would do. Because if we end up going down the road where we don't have as many clinical services, does that change? I don't know if the committee had that discussion.
Well, ostensibly, we had that discussion at the workshop. And we're going to discuss it further. The whole point of moving forward with a medical director is so that we can know, we need to know what we're doing and where we want to go. Now, what you're asking is, do we want to put the cart before the horse? We don't know what clinical services we're doing and where we want to go. This is a vital discussion. That's why I actually had Jessica put Commissioner Domke's questions up there. This is the central core question. But you're going to have medical direction and some mechanism to address that. But if you want to address it before we even have a mechanism to address it, well, then I guess that's another way to approach it. I'm not sure I quite understand the objection of trying to have a methodology here. Yes.
Mr. Chairman, I do have some additional information I'd like to share with the board. I have continued to work on this issue since the workshop to try to better understand the services that we provide and frankly, for lack of a better term, the competition that is in the same arena with us, and that is sliding scale services or
And you're welcome to talk about all of that on item 9. And I want to hear from you, but that's item 9. We're at item 8. And again, we're talking about the horse and the cart. Peggy, we need to talk about what our clinical services are and should be. I'm 100% on board with that.
Mhm.
So is Commissioner Domke. So is Commissioner Korn. I presume Commissioner Bertland. I mean, we all want to know. That was the whole point of the workshop. I remember you're expressing your thoughts going into the workshop. Gee, why are we having a workshop when I don't know. You had reasons to object to having the workshop. And I kept saying, we need to find out what we're doing.
Can I interface here? Go for it.
I did not have objections. What I asked for was, are we doing strategic planning? And that's when the title was changed to a workshop.
And
So
I
I had
accommodated. We
no-
made it a workshop.
I had no objections to it.
I think we could, that's noted.
Okay. Did we
Can I-
find
can
out
I-
about
Thank you.
the
Yeah.
code that takes us?
So my understanding is section 74-204 allows for the ad hoc posting of the meeting if it's in good faith and was not intended to be missed prior to doing it. If it was intended to be missed prior to doing it, it's not okay. We didn't intend to do that, so we're okay. Then subsection 74-206 limits the purpose to be outlined to subsection 1, which is R1, which is subsection 1 of Idaho Code 74-206 says to consider hiring a public officer, employee, or staff member or individual agent wherein respective da-da-da. So basically, it's subsection 1 of 74-206. A and B. Okay, and so correct me if anyone knows more, but I think that would be our declaration of why we're going into it. we have the authorization to do that for the section 204. Lynn, would you like to declare subsection 1 reason to do that?
My concern, cause, I rest, qualifications, et cetera, et cetera.
Mhm.
On the agenda, it says the report, the medical director selection committee report. That was what I was prepared to receive.
Mhm.
We received it. This is that committee's recommendation, which is good. We had an opportunity to ask questions, but at the same time, it seems like
But it's also an
adding to-
action item.
Yes, but the action item was on the report from the medical director selection committee. Whether we should accept and approve your recommendation. But that's a different thing when we're saying we want to hire that recommended individual for the position. Is what I'm saying.
Okay.
I like him as a candidate, but it's the process.
Okay, so it seems to me we've reached a binary. We either go into executive session, understanding that the spirit of the exercise was in fact to have an action item and move forward, or we kick the can down the road and I will call a special meeting of the board for sometime next week, which will be an executive session. We will then have the same conversation we're having now, make a decision, and then come out of that executive session, vote on it, and then we all are happy. That's a binary.
The other way you could do it is you would, I don't know how much, I mean, of importance this is. You would just table it and reword it and put it on for next month meeting.
I'm not willing to
No.
wait a month. I'm going to do this next week.
Okay.
Yeah, I would prefer to do it now.
Well, then make that motion. Well, then let's do it now. So would I personally, because there's no sense in kicking the can down the road still
What
again.
I'm saying is, the
I
process-
understand, but we've gone through the statutes and we are legal to go ahead and call an impromptu executive session.
Mr. Chairman, based on the discussion, I would make a motion that we approve the report of the medical director selection committee. And that we vote on their recommendation. So,
Well, no. We need to go into executive session. Am I understanding correctly?
that's the way it normally would be.
But we will go into executive session.
So I make a motion to go into executive session.
Bingo. Right,
Based off of subsection 1 of
right.
Yes. based on subsection.
274-206.
Do we have a second?
I'll second you.
Okay, so I would ask
A
that
and B.
everyone leave the room.
Thanks. Appreciate that.
No, I'm going to have everyone. Commissioner Cowles, are you still there? The selection committee made a recommendation, which I believe by Robert's Rules of Order actually stands as a motion. Do I hear a second to the motion?
I'd like to second that.
All right. Any further discussion after all that discussion? Hearing none, let's have a roll call vote to hire Dr. Pinnock as the medical director.
Chairman Fletcher,
Yes?
Glenn Bailey,
Yes.
Dr. Johnson,
Yes.
Commissioner Cowles,
Yes.
Commissioner Bertling,
Yes.
Dr. Nolan,
Yes.
Peggy Cavallo.
Yes.
Okay, it is unanimous. Congratulations. We have, you don't know what we committed you to.
That's why we asked you to leave. No.
All right, then let's go to item 9, which is the workshop follow-up. And I promised Glenn Bailey that I would turn the floor over to him since it was his idea to actually have this follow-up. So, wait, yes, ma'am? Oh, we're going to bring him back up. Yes, thank you. Thank you, public. Yes, actually, this is a good point. There we go. All right, so Commissioner Domke has specifically wanted us to address those questions. So we will before the session is over. But in the meantime, I'd like to turn the room over to Glenn Bailey.
Mr. Chairman, item 9 on our agenda for today was Board of Health workshop follow-up. Please prepare the board next on the conclusion of the May 10th public workshop. And I would like to propose that we come up with a timeline on meeting our goals and the direction that we want to go with clinical services. That would be my motion, is that we approve the timeline.
If I may be permitted to make a friendly addition to what you've said, I 100% agree. So I would propose the following, that we give our new medical director 1 month to come up with a timeline. And that the next meeting, he lays out, this is what I've come to understand. This is sort of these are the elements that still need to be in place, et cetera, and that he would pro-offer a timeline. And it might even be the case that he says, I have no clue what a timeline would be. I don't know, but at least give him a month to come up to speed and familiarize himself with what in the world is going on. I'll entertain anyone else's thoughts.
Maybe instead of a motion, maybe just follow up.
I like that. Oh, I like that. I think that's great. Are you okay with
I
that?
would agree.
Yes, go ahead.
I wanted, and Mr. Chairman, if you may, it may take a couple minutes, but I wanted to, I've continued looking into this matter on, I guess, how we ended up where we're at currently with clinical services. But I'd like to share that information
Please
with the
do.
board
Please
if
do.
possible. As I've shared with the board before, or in that workshop, we have seen a steady decline in services across core public health programs or Panhandle health programs. That includes immunizations, family planning, STD treatment and control, and women's health check. And we have seen, the only area we have seen increases is in primary care, and that's in the Care Plus program. And I know that during that workshop, we had quite a bit of discussion on asking questions, well, how did we get there? Is it the quality of care that we've provided? Is it timely access to care? Is it advertising? Are we not getting our name out there enough? I know I put some time into discussing Medicaid expansion and how that created additional options for individuals that otherwise were coming to our clinic for free or sliding scale services. We also discussed funding and possibly even outcomes of our patients. And I know I had conversations with a number of members, and I believe even with Mr. Pennock, we talked about looking at CPT codes and diagnostic codes to try to see what are we doing, what are we not doing, where could we focus. And in the past few weeks, and part of it was as a result of a conversation with health and welfare area federally qualified health centers, that being Phoenix Zoo Clinic and Heritage Health, I started looking into a little more outward instead of inward. And one of the things that became apparent with very limited research is that, and I guess I'll look at it from the standpoint, when I was a kid, as I mentioned before, my mom was a public health nurse up in Lawrenceburg. We had 3.5 FTEs, 3.5 nurses up there. We had robust services. That place was busy. So the question is, how did we get to the place where we have almost no demand for services in Lawrenceburg, limited demand in the other outlying counties, and primarily these who are serving two? And a lot of that seems to almost happen very quickly. In really looking into it, again, our competitor is federally qualified health centers, that they're the only other entity other than charitable care that provides a sliding scale. Looking into the matter, as a significant component of the Affordable Care Act, substantial funding, federal funding, was put into standing up these federally qualified health centers to the tune of $2.2 billion these in 2010 to $5.5 billion. What the result of this ended up being is you had less than 7,000 federally qualified health center sites, and that moved up, ballooned to 15,500. It doubled over the course of the past 10 years. Here locally, what we've seen, and looking at calendar year 2022 filings by Connexu and Heritage, Connexu is receiving somewhere in the tune of $3.3 million to stand up clinical services. Heritage is somewhere around $4 million. In addition to that, they have access to, or have had access to, capital improvement grants. So not loans, but grants. And there's actually a case where they had Heritage had almost a $4 million PPP loan that was forgiven. So when you want to talk about that in respect to the Panhandle Health District, for FY26, we're looking at receiving about $370,000 of federal pass-through funding. So we're seeing a tenth of the funding to provide programs that federally qualified health centers are providing.
With that, have you been able to identify yet what is the driver of the disparity? Is it more of just things that we haven't applied for, or is it more things that we can apply for that they can or no, or what's the disparity on that?
That's correct. You have to meet a certain model, and as a public health district, we do not qualify for those funds. And to add to that, the legislature in the last section, and I brought this up before, is looking to take that $370,000 that we do receive, and they've directed health and welfare to not look into it, but come up with a transition plan of moving that funding to the FQHC. So that bit of funding that we do have is heading that direction as well. So from that standpoint, when you're looking at entities that are receiving 10 times the amount of funding that you are to stand up clinical services, it makes sense why they would have dental services, pediatric services, vision services, you name it, in a comprehensive type of setting. And to be honest with you, I can't, in good faith, recommend or support that we continue services here when I'm hearing from commissioners that we shouldn't be providing duplicate services. So from that standpoint, I wanted to share that the federal government has basically thrown their weight in behind FQHCs in a manner that local public health and local supported programs really does not seem like a model that is destined to survive in the current setting. A few items that I would like to share, though, where I have concerns, and And this also comes from the phone conversation with the federally qualified health with Kinexu and the CEO of Kinexu and Heritage Health. I think it's Kevin Nepper, who's the CEO of Kinexu. He has mentioned that he has concerns with the viability of federally qualified health centers because they are very dependent on federal funding and they're very dependent on enhanced Medicaid and Medicare reimbursement rates. The challenge with that is that, and one of the commissioners that I spoke to yesterday is, the current federal administration has expressed that they're not huge fans of the Affordable Care Act. That being said, it makes it questionable on what their viability is in the foreseeable future. They may continue to be funded, they may not. There may be reductions. I don't know. And I just thought that it was critical that the board be aware of that. The other piece of this, and this isn't really for our board's consideration, but I know we've talked about it, is that as preventative services, such as those provided by the Panhandle Health District and federally qualified health centers, if those become limited, that demand does shift toward our rural hospitals and our area hospitals. And I know talking with Commissioner Bertling that the Boundary County Community Hospital has challenges. I know speaking with Peggy, the Benoit Rural Hospital Community Hospital is also experiencing challenges. So there is certainly an access to healthcare issue that is playing out right now. But as far as, and I do believe that my comments speak to Commissioner Donke's questions on what is the role of the health district if you have Kinexu and you have Heritage Health that are already providing those services and are frankly in a at least currently in a position that they're receiving drastically greater funding to provide those services than we are.
If I can reflect before you could potentially address question one. It sounds as if you're presenting to a dichotomy of there's other federal health qualified facilities are basically getting outfunded by us potentially 10 to 1, but yet they're dependent on potentially fickle funding that may or may not shift with the wind of politics and whatnot. And so then therefore right now they definitely outcompete us and they can then outpay us, but largely because they are getting some of like you're saying, the different reimbursements and things that they're getting access to that allows them to pay staff more and all of that to keep their doors open. But then if that shifts away and is no longer available, then those services will then need to come back and be available through the public health districts potentially. I don't know if there's and if you could speak to as director your understanding of what are there any specific services that we're mandated to, or are we just contracted to? Kind of different between there, and which ones do we officially do that they're not willing to do or can't afford to because they don't make enough money?
I don't believe that we're mandated to provide any services. All of the services that we provide in clinic are through contract or grant with health and welfare, whether that be state of Idaho funding or federal aspect.
And then as far as the question one, I guess too, is like, are there specific, I think when we were talking before, they came up with, I think the smallpox vaccine was one that nobody else is willing to offer right now.
I don't think it's that, but travel vaccines, yeah, are a bit of a niche. That's what District 2 and District 7 are holding on to because area providers do not tend to stock yellow fever or more exotic type diseases. So, and the other aspect of that is that my understanding is most insurances do not cover that, and so when individuals come in for that service, they're paying full price. So it's not augmented by county support at all.
So that one doesn't necessarily have anything to do with income disparity or anything like that. It's just
Correct.
Someone who wants it or needs it. They come in for a yellow fever or that sort. And are they currently not being offered by the other federally funded facilities? Is that correct?
So that's my
So short of those, Is there anything else that we can or have offered that they don't continue to offer? Do you know?
No. And the conversations that I did have with commissioners, I guess in the last week, some commissioners, commissioners up in Boundary County, as well as some commissioners in Bonner and Kootenai, were really general in nature and certainly at the discretion of the board. But that if we are providing duplicate services, is there better uses for the county support that we have to augment other programs, other areas that we haven't explored that the board should be looking at or should be considering? And I did certainly ask those commissioners that we were open to their ideas. On that note, again, I guess the other thing that I would mention on that is, sort of a question of timing. The commissioners that I did speak with, they were varying ideas on how to phase this out, and if that is the will of the board. Part of that does beg the question of what's going to happen with federally qualified health centers. I did try to do a little research before this meeting on the funding for the federal fiscal year 25, and at this point, it does, at least the FQHC organization's official site is saying that their funding is uncertain. So, someone, but I just wanted the board to have that information at their disposal when they look at weighing in on this.
Okay, on that, if you don't mind.
Sure.
So basically, where we potentially do things specifically where they're not doing would be maybe in more of our preventive services and then some of the more of the outreach programs and educational programs and all of that. And that's something that they're not offering.
That's correct. And thank you for bringing that up, because there is a lot more to public health than clinical services. A number of the core programs that we still do, our environmental services continue to grow as the area grows, so we have very much an increased demand in those services. Those aren't duplicate services, they're regulatory services. Also our epidemiology services, our health promotion services, certainly our WIC services and nutrition services are significant and frankly significantly used throughout the 5 million counties. And so the funding is very stable in those programs. So there are a number of things that we do and that we do well. And I guess I should caution my comment on that and say, I really do believe that historically the Panhandle Health District has provided outstanding clinical services. And we have had outstanding providers, and we still have outstanding providers. The reality is that the sheer funding, it went from where, Heritage and Kinixu were, ancillary to the services of the Panhandle Health District, but with this infusion of tremendous amounts of federal funding, it has changed that dynamic.
Thank you for those remarks. Any comments from any board members? How about comments from public? For Commissioner Korn, sure.
Yeah, so from a county standpoint, from our county standpoint, we don't have the exact number in front of me. We're pitching about $500,000, I think, to the clinical services, and we get 1 day a week. And so we're not seeing the return from our taxpayers' money to support that.
Sure.
Approximately it's about $400,000, and it's not just for clinical service, it's for all of the services provided by the health district, all of the services that I mean, environmental, epidemiology, WIC services and so forth. While we do collect fees, some fees in environmental services, there are a number of fees that are set in statute that do not remotely recover the cost. So that amount of county contribution covers all all of the services of the health district.
Eric, do you have readily available by county how much of all of the total money given by each of the Board of Commissioners goes to the clinical services specifically in their county? If not, that would be a very helpful number to.
I
To-
don't
to
know
have.
what I can share because county support is not necessarily specifically bidding programs. It's support for overall operations. But what I can share is that for fiscal year 26, we did allocate $363,000 of county support dollars to support the clinical services.
And that's a conglomeration of all 5
That's
counties.
all. That's the total amount. So, I mean, if you wanted to start splitting that out based on the equation,
Yeah.
Cooney County 67% of that, Bonner County is 20-ish, 20%, and then the remaining counties are 10. Yeah.
So Bonner's was maybe 70-ish, plus or minus a bit.
Ma'am, did you have a comment? Your hand is up.
I just, didn't want to kind of go into the public perspective, and I would just really beg of you to consider taking the money that the public health department has and applying that principle out from the ounce of prevention for the pound of cure. And I know I have recently been in conversation with an integrative dietitian. She's a registered dietitian. However, she has quite a flourishing practice of treating people with modifying their nutrition. And she is seeing people come off of SSRIs, which we all know are causing lots and lots more problems for those people as well as those around. And if we can move into an area, people, there are families that don't have enough money to go around, and we could teach them home ec, just as simple as that. They need to know how to make good choices, how to cook, how to better provide for their children. I would just ask that you look into prevention, and I think that would go a long ways towards the list that Dr. Pennock talked about, and all these other things that we could be affecting before they ever go to the doctor. We need to avoid that.
And if I may, we do embrace that wholeheartedly, and frankly, that is information of the Panhandle Health District. And to your point, we've had, in addition to nutrition services providing, the WIC services, there have been programs that have come up throughout the year to assist people in preparing fresh vegetables, what to buy, how to have healthy meals. So we fully embrace what you're saying and to incorporate those as possible.
I remember, there was like $1.5 million for clinical services, wasn't it?
No, it's 400,000.
Yeah, the total budget, the total expenditures for fiscal year 26 was anticipated at 1.8 million, but the county support to that would have been 363,000. The remaining would be either contracts and grants, or it would be reimbursements from the insurance or Medicaid.
Whatever the amount, I would beg that you.
Absolutely.
Any other comments? Staff, you want to make some comments? I don't, Christine, you're always quiet. We are talking money here. All right, so in the spirit of what Peggy said, we're not going to actually make a motion per se. We're going to just bring the topic back and develop a timeline at the next meeting, and perhaps even a crude understanding of the framework and the person who will be front and center, quite frankly, will be our new medical director. Does that fairly summarize the spirit of this conversation? Okay. That being said, this is not an action item. Let's go to the director's report, number 10.
Thank you, Mr. Chairman. I'm just simply bringing to the attention that the health district, among I think 29 other entities, were named in a recent federal lawsuit. We have been working with risk management and And an attorney has been assigned to represent us, but we believe that our exposure is very limited, but I wanted the board to be aware of the matter. The second item that I did, it's not on the agenda, but just simply to make the board aware that we are currently going through our fiscal year 24 audit by legislative services. Mr. Chairman, I expect they'll be in contact with me to have some questions regarding our presence with some brief questions. But otherwise, we'll keep the board apprised of the outcome of that and share that with you.
Okay, that's fine. Any questions for the director? Hearing none, let's go to the item 11. The hour is late. If you have just this burning desire to hear me speak, I can proceed. Otherwise, it is a short lecture, which I could give next month or anytime. But I can see one human being's ready to bowl.
Well, I'll watch you on YouTube. I promise I'll watch.
Oh, well, you can either. I mean,
I'll do the same.
do you want me to give the lecture? I mean, I can, or not, or wait. It's,
Well, the forum will really.
oh, yeah, we'll need to.
So you need to-
Melissa, are you still there?
Oh, she's here.
Yes.
Okay. You know, it's been a long meeting. Why don't I propose to just do this next time? Is that okay? The information will still be there.
Oh, yeah. I've read, yeah.
It might be updated.
Okay, then we have a motion to adjourn. Do I hear a second?
I'll say.
Are there any objections? Hearing none, the meeting is adjourned. Thank you, Commissioner Cowles and Bertland.
Thank you.
Thank you. Have a good day. All right.